This session will be started with the opening remarks and a brief presentation by Prof Malik Pieris providing the current overview, and following that brief presentation we'll be moving into a question and answer session where I will be discussing the areas that are relevant to, then followed by questions from the audience. You can send your questions through chat, and then we'll be forwarding the questions to the resource person. And I can see a lot of prominent resource persons and medical experts in the field in this forum. So we should be able to provide opportunity for them also to select a part of this discussion. Without further ado, I'd like to open the forum for Professor Malik Pieris for his opening presentation. Over to you, Professor Pieris.
Thank you very much, Indika. And it's a particular pleasure to be to join this particular forum because, as was pointed out, it's an organization of many professional associations, and as was pointed out, a problem of this magnitude really requires multiple professional input. So in discussion with Indika, I'm going to keep my remarks fairly short so that we have more time for discussion. Right, so I will do a very quick update on the global, but mainly the Sri Lanka situation. But again, my colleagues Indika and Manoj are probably better informed about the local situation. Right, so some of the slides I will be using, I have to acknowledge the WHO country office in Colombo, and also my colleague, Professor Gabriel Long, who used some of these slides for his presentation last week at the WHO R&D Summit. So this slide just shows the global situation with COVID-19. And as you can see that by February, things were looking quite good. The overall case numbers were coming down, but unfortunately, you can see now from March, April, the global case numbers are going up. But the more concerning thing for us here in Sri Lanka is that the numbers that are going up are because of this purple colored part of the bar, and that is Southeast Asia, exactly where we are. So essentially what we're having now is a major outbreak, a series of outbreaks in India, in Nepal, in Bangladesh, in Sri Lanka, but also in Malaysia, Thailand. So this whole region has become a hotspot, sadly. Now, I'm sure you have seen the very distressing images that we see on the TV screens from India. So what exactly happened? What you can see at this top chart, I hope you can see that well, but essentially you can see the case numbers suddenly increasing over the last few months in India. Now, on this lower chart here, what you see is what is called the stringency index. That means the stringency of public health and social distancing measures. So you can see that the social distancing measures were dramatically reduced and things were quite relaxed for quite a period of time before the lead up to this particular upswing. Now, of course, the vaccination program has started in India, but as you can see, it is still only about 7% of the population have even received a single dose, which is not very different to Sri Lanka. So the causes for this major upswing in India, partly, importantly, is the relaxation of the public health and social measures since October of last year, the low vaccination coverage, of course, and importantly, also the emergence of a more transmissible variant, and we'll discuss this. I'm sure you have heard about the so-called double mutant. Now, what you see here is the impact of this double mutant. This is globally across India, and you can see this green part of this chart. That is this new variant virus called B1617, the so-called double mutant that was first described in India. All these other ones, all the other colors are other variants. So you can see very rapidly, once this particular variant has emerged, it has squeezed out all these other viruses. And this is a classical signal suggesting that this virus is more transmissible than all the other viruses that are circulating. And also among them is this purple one here, which is B117, which is the UK variant that is currently circulating in Sri Lanka. So this, the double mutant that is in India seems to be much more efficient than everything, including the variant that is present in Sri Lanka. Now, I was particularly concerned when I first heard about this some months ago, because there was an upswing of cases, even in places such as Maharashtra, which is where, for example, Mumbai is, because I knew that by the end of last year, what are called seroprevalence studies, that is looking at antibody in the population on a population basis, showed that in that region of Maharashtra, about half of the population had been already infected in the first wave in that Indian outbreak. So the fact that there was a second wave that was sweeping through a population, which half of the population should already have immunity, was very concerning to me, and it remains very concerning to me. So the question is this new variant able to evade, at least partially, pre-existing immunity by natural infection and also by vaccination? Now, what is the situation in Sri Lanka? I'm sure you're familiar with this, the pattern here. We had a first wave, if you like, then we had this second big outbreak, starting with the Minwanguda cluster and then going on. And then, of course, just in mid-April, you have this huge increase of case numbers. And then, sadly, of course, inevitably, you have this black line, which indicates deaths. So keep in mind the scales for the blue chart and the black chart are different. So this is the scales of the deaths here. And you can also note that inevitably, the deaths lag the cases by a period, by at least 10 days or 2 weeks, right? So the impact on mortality of this huge increase of cases, we still have not felt. That will be felt in the next couple of weeks. So if you just look at the case increase, now this is data from the WHO office in Colombo. So if you look at 3 weeks previously, there was a huge increase, and then week on week, there has been an increase of cases. There appears to be a moderation in the rate of increase, but again, we can discuss that, how reliable that may be because of a number of factors of testing. But then again, we have the deaths increasing on a week-by-week basis, continuing to increase. So we do have quite a worrisome situation on our hands. And again, if you look at the reasons for this, again, there was relaxation of public health measures, particularly, of course, over the Sinhalese New Year period, when there was a lot of people moving around, a lot of shopping, a lot of travel across. So that gave the virus a huge boost. But then, unfortunately, exactly at that time, very early in April, as was reported by Professor Malavige and colleagues at Sri Jawaharlal, a new variant was detected, this B117. This is the variant that was first not discovered, but detected in the UK. And then, of course, combined with that, we still have low vaccine coverage. So the same three factors that are present in India, unfortunately, are present here and contributing to this big outbreak that we have. Now, before I go on, I just want to re-emphasize that the transmission of the virus is not really changed in the modes of transmission. It is much more transmissible, as I will point out, compared to previous viruses. But the modes of transmission, the mechanisms of transmission essentially are the same. It is just that the virus is able to transmit more efficiently. So the modes of transmission is when somebody breathes or coughs, you have these large droplets which may fall to the ground within a meter or two. But then there are these very fine airborne particles that remain suspended in the air. Now, there's been a lot of controversy and a lot of excitement about this airborne spread. But indeed, from last year, we have been essentially saying that COVID is spread by both these routes, large droplets as well as airborne particles. What is important, of course, is that although the fact that you have infectious particles floating in the air can mean under certain conditions that you can have transmission over quite long distances, the distance to the source is an important factor in terms of concentration of dose. So that the closer you are, the higher the dose of these airborne particles you're going to get. So what it means is that distance is a protective factor. Ventilation is a protective factor because these will reduce the dose that you will get exposed to. And one virus particle will not infect a person. You really need to have a minimum dose to initiate infection. We also know that masks reduce the spread of virus from infected person and also reduce the inhalation of these infectious particles. And we know that this infectious material can contaminate surfaces. So if you may touch these contaminated surfaces, and that's why hand hygiene is important. So as I said, these are the same routes of transmission. It's just that this new variant is much more transmissible through all those routes and also through other mechanisms because the period of infectiousness of an individual seems to be longer. Right. So when we look at transmission of any epidemic, there are a number of factors. You have the virus itself. So about the virus right now, what is most concerning are these new variants. You have the public health and social measures which control contact between individuals because the virus, in order to spread, really you have to have person-to-person contact. Then, of course, you have environmental factors, temperature, humidity, ventilation, very important. And finally, of course, you have immunity in the population. Now, sadly, at the moment, of course, because the only way you can get immunity is either by natural infection, which we don't want to get anyway, or by vaccination, which we are trying to get. So let us consider each of these in turn. Firstly, the question of the virus factor, and in particular, the viral variant. So this is a schematic of the SARS coronavirus 2. You have these proteins sticking out of the surface of the virus, which attaches to the host cell. As with any virus, it has to replicate inside living cells, in this case, in human cells. And when the virus replicates, being an RNA virus, it continues to make occasional mistakes. And these are mutations. Now, most of these mutations are bad for the virus. Essentially, the virus does not survive. So we don't even see it. Quite a number of these other mutations have no real effect, either positive or negative for the virus. So they are of no biological significance, but they can be used to track the virus. In other words, who gave the virus to whom. But a few of these mutations confer advantage to the virus. Now, this is just a random process of trial and error from the virus's point of view. And those rare mutations that give an advantage, of course, will get selected and will gradually become dominant. Now, it's important to remember that from the virus's point of view, there is no real advantage to the virus for increased disease virulence or severity. The virus is only concerned about transmission, right? Essentially to propagate its genome. Now, if you then look at how the virus has diversified from the time of its first emergence in Wuhan, and this is a very simple schematic, basically something like a family tree. So you have your father, your great-grandfather, grandmother, great-great-grandmother, etc. So this is a family tree. You go back to Wuhan or wherever it started back last year, and over the time, it has diversified into different lineages, if you like, families or whatever it is. And along the way, one of the important mutations that took place very early last year, around February. Now, again, I'm not sure whether you can see this particular chart because it may be hidden, but this is this mutation called G614G. And very rapidly, because again, it's a mutation in this protein that the virus uses to bind to the cell, it improved the binding of the virus to the cell so that within a matter of months, the global population of virus became dominated by this mutant virus. Now, luckily, it didn't get to Sri Lanka immediately, but the Minuwangoda cluster essentially was the first introduction of that variant virus into Sri Lanka. And as we know, that led to a major increase in cases, Minuwangoda, the Paliyagoda outbreak, and then the virus did change its behavior, as we all know. Then, of course, the next major significant change of the virus was first detected in the UK, and this is this B117 virus. Again, a number of mutations, particularly again in this spike protein, which allows the virus to transmit more efficiently. So this was first detected in this part of the United Kingdom in October, but you can see that within 3 months, it had spread to dominate the whole of the United Kingdom. As I said, it has a number of mutations, but in combination, it makes the virus at least 50 to 70% more transmissible than previous viruses. It possibly does have a slight impact on increasing severity. Now, the good news, if there is any, is that this particular virus does not escape from antibody immunity. That is either from past infection immunity or from vaccine immunity. So the vaccine will effectively stop this virus. It also has one of its mutations results in a signal in one of the particular PCRs, and that is what is called this S gene target drop, which was how the virus was first detected by Professor Malavige back in early April, and then confirmed by sequencing. But there are a number of viruses of concern, but the other virus, of course, that is close to us is this B1617, which is the so-called double mutant that was first detected in India, initially detected in October, but rapidly increased across India, but particularly, as I said, in places like Maharashtra, in spite of population immunity. It has got multiple mutations again, and some of these mutations have been found individually in other viruses in the USA, in South Africa. And these mutations individually, we know, are undesirable. They increase transmission and also potentially allow the virus to partially escape immunity, past immunity, and potentially vaccine immunity. So this was really, as I showed you, the virus that is dominating the outbreak in India, and it has now spread out of India. It is now causing concern in the UK, and where it is possibly spreading faster than the existing virus, the UK variant B117. You might have heard of outbreaks in Singapore, including at Changi Airport, also caused by this same virus. And the big concern, as I said, is the concern that this may have the capacity to partially, at least, evade the immunity that is elicited by vaccination. So in other words, of course, it is unlikely that it will completely escape vaccine immunity, but we really don't want anything to reduce the efficacy of the vaccine. And that is exactly the reason why we should do our very best to prevent this particular virus getting into Sri Lanka. And in that situation, it is extremely disappointing, I must say scandalous, that there have been people who have been trying to entice tourists from India into a pseudo quarantine type of setup. I mean, of course, anybody can come in to any country, including Sri Lanka, but as long as you go through the proper quarantine procedures. But if you evade quarantine, if you have contact with other people without very strict measures, that is a recipe for disaster. And I really hope that we know that already Professor Malavige has reported 2 instances of detecting of this virus, but we don't know whether it is spreading out in the community. If it is, it will be extremely bad news. And in this context, before I leave this, I just want to point out, and this is important because this is a multidisciplinary forum and we are hoping to have a good discussion later. I mean, we completely understand that the economic aspects are important. In that regard, tourism is important. Some of my closest friends work in the tourist industry, and I know how badly the different aspects of people working in that industry have been affected. Now, you can try to bring back tourism. Of course, not at this stage, not right now. Nobody's going to want to come to Sri Lanka now. As you know, Sri Lanka is on the red list of a number of countries. But if you go back some months when the situation was a bit more calm, one could have targeted countries where the outbreak was under control. For example, the classic case would be China. I mean, that would be a great place to attract tourists to Sri Lanka from in the past. Unfortunately, what happened was we tried to attract tourists from the worst places. And of course, most recently, as I tell you, from India. So this is just to emphasize that we are not forgetting about the economy, but we have to be smart about how we protect and how we support the economy. Right, so come back to this same chart. We talked about the virus now. I will briefly talk about the immunity, the vaccine immunity, and then talk about public health and social measures. Now, we have vaccination, and vaccination is being rolled out. As of now, about 6.5% of the population have been vaccinated with 1 dose and about 1% or a bit more with 2 doses. The general population in large parts of the country have not had access to vaccine, except for healthcare workers. So the vaccine rollout has been primarily focused on 1 or 2 provinces. The vaccine has not been targeted at the highest risk groups, which are the elderly and those with comorbidities. Of course, rightly, the vaccine was targeted at healthcare workers, which are fundamentally important. They're a high-risk group. But next to that, in most countries, UK, USA, Israel, Hong Kong, wherever, the vaccine rollout has been systematic from the oldest population downwards. And if even this 6% of vaccine had been targeted to the high-risk groups in Sri Lanka, the elderly and those with comorbidities, at least part of them, we probably would have been in a better place now, at least in terms of protecting from mortality and ICU admissions. Now, the vaccine supply remains a constraint. Now, this, of course, is a global problem, without a doubt. And I mean, I commend the government for doing its very best to try to secure vaccine. Now, there is a delay between starting vaccine and the vaccine having an effect. So you need 2 doses, particularly of some of the vaccines available in Hong Kong now. You need the 2nd dose, and it's about 2 weeks after the 2nd dose that you have maximal impact. With AstraZeneca, you do have some protective effect from a single dose. So the vaccine is clearly a part of the long-term solution, but it's not likely to impact the current problem that we face, which is hospitals being overloaded, the healthcare workers being exhausted. So the question is, how do we get there, a vaccinated population from here where we are? And we have threats from a number of variants. And it's not just the variant from India. There's also a variant in South Africa and a variant in Brazil, which are evading partially the protection from vaccines. Right. So let me now talk about the public health and social measures, which is what we have on hand to contain the challenge that the country faces right now. Now, you have seen some of the interventions that have been put into place. For example, limiting travel between provinces. But if you just look at the data, if you just look at the cases during the last seven days, you can see that now cases are present in every province in the country. If you look at the increase compared to the previous week, you can see that in most provinces, there is dramatic increase. So stopping people moving from one province to another is not really going to reduce transmission at this stage. maybe if it had been introduced back in the middle of April, it might have had an impact, but not now. Then, of course, there is the talk of lockdowns. Now, how do lockdowns work? Now, this chart shows the propagation of an epidemic. So you have one infected person, he or she meets 2 or 3 other people. It may transmit to one person or 2, and then onwards and onwards. Now, what is achieved with a lockdown is that you compartmentalize these people into households, in theory, right? So let us say this person is infected. Within that household, there would be maybe very likely transmission to 2 or 3 other people in the household, whoever is there. Hopefully, most of them will be mild and asymptomatic. If somebody is seriously ill, that person will be taken for care in hospital. But as long as it is confined to one household, the virus has no chance of spreading further. And once the virus runs out of people to infect, it burns out, it dies, because it cannot survive hanging around in thin air for days and days. So how long does this lockdown have to be? Overnight, keeping people at home? Obviously not, right? So there is a science to this. And the science is based on the period of infectiousness of an individual. So let us say this person was infectious at the beginning of a lockdown period. Now we know that the period of infectiousness of an individual is 5 to 7 days. So if this person is infectious at the beginning of a 3-day lockdown, he will remain infectious at the end of the 3-day lockdown. He'll be out in the community on the 4th day and the 5th day, right? Then there's another issue. That's the incubation period, meaning from the time you get infected to the time you develop symptoms and become infectious. And that the median is about 5 days. So let us imagine this person in the household was infected. There is a lockdown. He may transmit to other members. And this interval on average would be around 5 days. So these people might get infected. Now they have to now become non-infectious, which means 5 days plus another 5 to 7 days, 12, 13, 14 days. So this is why 3-day lockdowns are going to have minimal effect. So I would end here and I just summarize the situation. And my colleagues, Indika and Manoj, can have much better first-hand experience. But from everything I hear, the health system is at a breaking point in terms of the clinical staff, nursing staff, the public health staff, the PHIs who are doing a fantastic job, the laboratory staff who are working under tremendous constraints. Everybody is exhausted and at breaking point, probably beyond breaking point. So we, I think, are at a tipping point in this whole situation. So I'm sure some of you, those of you in mathematics, in engineering and whatnot, fully understand this concept of a tipping point when beyond a certain point, things go out of control, then the problems don't increase in a linear fashion. They just spiral completely out of control. So we are in urgent need of a circuit breaker to rapidly reduce transmission, contain transmission, so that the health system can take its breath, literally speaking. Then, of course, we have the question of how do we balance the control of this pandemic with maintaining the economy. And this is definitely something that we should discuss, and I hope we can discuss it during the Q&A session. And finally, I just want to highlight the dangers, the twin dangers of complacency and exceptionalism. And I think exceptionalism is what the United States suffered from in the early part of last year when it thought that it had systems that was good enough to deal with this virus. And indeed, India probably thought the same thing, that it will never affect us. So I really hope that Sri Lanka does not also think that we are exceptional and that this virus cannot go out of control in Sri Lanka. So with that I will end, and I really look forward to the discussion together with my colleagues, Indika and Manoj. Thank you.
Thank you, Professor Pieris. I actually cannot think of a more comprehensive count regarding the current situation, covering all the necessary areas, including the virology, epidemiology, the vaccination, and the economic aspect, and the possible issues that we are facing. However, the most important thing that you have mentioned was that we have reached the tipping point and the breaking point. So that may be something that we need to discuss in further. And you have very correctly mentioned that the patient numbers are increasing. What I want to ask is, now we see when you look at the epidemiology curve, we see the patient numbers are almost say the same, like 2,500 per day or 2,400 per day. Last 4 days, it has remained the same. What do you think? Is it the real picture? If not, what could be the current situation? And maybe the predictions for the next back from my co-moderator, Prof Malik Pieris.
Yes, so I think certainly, I think Manoj can also comment on this. I'm sure he's very expert at this issue, but I think the problem is, I mean, of course, it is good to see that the cases are not continuing to increase. But the question is this the reality, or is it an artifact of testing? What we know is that the testing capacity has flattened. So it is now not increasing anymore. Even if there are more cases, even if there is more demand, it doesn't have the capacity to increase. So in that situation, you will basically have flat numbers of cases limited by testing capacity until such time as the percentage positivity goes up. Now, for the percentage positivity to go up, that is a greatly lagging indicator. That would happen only when the situation is much, much worse. So I have my doubts as to whether the plateauing that we are seeing now is a genuine plateauing of the outbreak or not. And I don't think for public health control, given the situation that the healthcare system is at this moment, we can take a risk on that, making an assumption on that. Over, but I'm sure Manoj can comment on this.